Well, welcome back, everybody. This is the third session of the Fall Virtual Learning Collaborative. This will be the halfway point. We're glad everybody is back with us. I am going to quickly introduce the Optum team, the steady folks. We have a guest speaker today, and I'm going to introduce him, Derek, when he takes over control of the slides. But I'm Carol Dahl, and I'm with Optum, and I'm on the Medicaid ACO side of the business. Sherry?
Hi, everyone. Welcome. Sherry Almy again with Optum. I'm a peer of Carol's doing the same kind of work.
And Kim, I don't know if you want to introduce yourself. Kim Reed is signing on as a guest with us today. She's going to be one of our guest speakers presenting a case study 2 weeks from now at our fourth session. Kim, are you on?
She's
All right,
there.
she might be
on
mute. So Kim, it will be worth waiting for in 2 weeks. And Derek is on the call, but we'll introduce him when we get to his session. Natalie, who hosted the call 2 weeks ago, will be joining on. She'll probably be joining on in a little bit. Just a reminder, logistics, everybody's been great. You've been signing on early so we don't waste precious time doing roll call. For halfway through, I feel really good when I see some of these names. I think, oh, it's great. It's Laura from Illinois. Thanks for signing on today, Laura. I too am in Illinois, and it's a beautiful day. Or I see our famous Alaska contingent. So thanks for hanging in there. Each week we get to know each of you and your orgs a little bit better. So thanks for hanging in there with us. Don't forget to put your phone on mute, and if you look at the top part of your screen, there's a little icon. Turn that off so we don't have any feedback. A guest speaker, all of our speakers today will present material, but they'll stop, they'll see if you have questions or verify your understanding, but please don't be shy. You guys have been rocking it, utilizing the chat box, so we try and monitor that for any questions. So, you know, if you don't feel comfortable speaking up, utilize the chat box. We'd love that. Y'all know every session we have homework. We'll be getting to that in a little bit. I have not gotten any questions from you guys, so you must be summa cum laude kind of people. Don't be shy. If you're not understanding a homework or you need a little tutorial, please reach out to me, and if I can't answer it for you, we will get you a SME that can help you. We really appreciated every session AJ and I talk, you know, how did it go, what went well, how can we make it better, and in the spirit of performance improvement. We really appreciate when you complete the Survey Monkey. So, you know, as soon as you're done with this call, try and make it a point to complete that, okay? So what we're going to be doing today, session 3, in a little bit, I'm going to be reviewing what we did in session 2. We're going to be reviewing the homework. I'm going to be looking for 2 volunteers, not the folks, I think it was Leanne and Megan last time, the Alaska contingent and Hudson, but 2 other groups that could help us. We'll be reviewing the homework from session 2. And really excited as we move along in our journey to get into session 3. Very, very important. How do you go about identifying who your care partners are going to be? We're going to go through the business rationale for that based on your population needs. We're going to be talking about how to identify those partners. How are you going to structure that relationship? There's different vehicles in order to do that. Derek will amaze you with his abilities, and he's a data guru, and he makes data come alive. So how do you look at your network? How do you use data that's available to you to decide, you know, who do you need in your neighborhood and how are you going to pick? And then we're going to go through session 4. So with that, before we get into the homework, let me just kind of summarize what we did at the last session. Session 2, if you'll remember, was how to go about identifying what your population needs. So we looked at different ways to look at your population and look for the pockets, look for the opportunities, look for the different patient cohorts that existed. And we talked about different ways that you could identify those cohorts, and then based on that, determine what type of integration would be needed to make that come together and hopefully achieve the outcomes you're desiring. We talked about doing, utilizing predictive modeling, whether that be with claims or using your clinical data. We talked about the use of HRAs, the health risk assessments. Simple things that might be readily available to you, but given what you have, what are your demographics? What is your population like? And then based on that, starting to look at what were partnerships needed in order to help you with the different cohorts of patients that you identified. So with that, it's quick sort of summary what we did in session 2. With that, I'd like to move us into, I think, the fun part of our session. It's your opportunity to take content that we presented. And I should also summarize, we had a fabulous guest speaker last time. Your evaluation showed that Lee Miller really rocked it. You guys enjoyed the case studies, and she talked about the Tennessee Medicaid experience. So for session 2, what we're looking for, what we asked you to do is look at 2 different groups of patients. You know, we call them the chronic big 5. The asthmas, the CAD, the CHF, the diabetes, those folks with, high risk conditions that have high risk or high gaps, unmet needs, gaps not closed, or they've been utilizers of services such as ER trips or unplanned inpatient. And then also looking at those that have specialty kind of conditions, rare conditions, disease specific, but they've got a high dollar allocation to them. Whether that's MS, ALS, scleroderma, hemophilia, sicklers, that kind of thing. So what I'd like to do at this point is I'm looking for 2 volunteers from 2 different orgs to talk about how your group looked at these 2 different types of patient cohorts, and what did you determine would be the type of care that these people were going to need? And what's also important to us is, how did you determine that? How did you go about deciding what was important and why? And then based on the identified needs, what did you think about in terms of integrating to meet the needs of these folks? We're asking you for a lot of things here. And then from that, what are you going to do? What are the implications as you look at a value-based contract? Sherry, did that make sense? Do we need to clarify that a little more?
Yeah, I think the only thing was that they could pick one of the above, or they could pick their own as well. So I think if anybody has already done some work in this area and you've got a cohort that you're working on today, they could use that as well.
Okay.
Hi, we'll go ahead and jump in there. My name is Annie, and I am a psychologist at Providence Family Medicine Center in Anchorage, Alaska, and I have in the room with me some of all of our nurse case managers. And we've been working really hard here at the clinic to meet the needs of our patients who utilize the emergency room. We identified this cohort based on system feedback. So our hospital affiliate had a lot of concerns about folks who were high utilizers of those emergency services. All of our nurse case managers also make follow-up phone calls for patients who have been in the emergency room recently. And I think kind of anecdotally, they were noticing that folks who went to the emergency room had a lot of psychosocial barriers to accessing primary care or to following through with treatment plans in primary care that resulted in presentations to the emergency room. And so as a clinic, we decided a while ago that we really wanted to focus on this particular group. And I'll share just one thing that we've done to try to meet the needs of this cohort. So here at Providence Family Medicine Center, we are a fully integrated direct care team. We have social work, nurse case management, behavioral health, pharmacy that all works as a team with our physicians and their CMAs. And so one thing that we've done is to establish a group medical visit for patients who have recently been discharged from the emergency room or from inpatient stays in the hospital. This group visit occurs every single week on Tuesday afternoons, and any patient who's recently been to the hospital can come to that group, barring just a couple of exceptions. Right now, we're only able to offer that group for our English-speaking patients, and we're diverting OB patients and folks who went to the hospital primarily for a behavioral health-related reason, like suicidal ideation. But everyone else is eligible to attend that group. It operates every week so that there is guaranteed access within 1 week of a patient going to the emergency room. During the group visit, the patient has an opportunity to meet individually with a physician, but the entire integrated direct care team is represented there. So there's always a behavioral health provider, there's always a social worker, there is almost always a nurse case manager there, and there's always pharmacy students who are there to help with med reconciliation. The group meets for an hour and a half. Typically, we have a few minutes at the beginning to have some group conversation about common concerns that patients have that lead them to the emergency room, and then common questions patients have when they are discharged from the emergency room. And then we have an opportunity for those patients to meet and have a medical evaluation by a physician. And in the meantime, while they're either waiting to meet with the physician or after they're done, they have an opportunity to meet with the integrated direct care team. And so we're able to problem solve some of those psychosocial barriers that are in place for them. So, for example, for folks, we have got them registered for Medicaid during that appointment. We have had them meet with a nurse case manager to start problem solving accessing durable medical equipment, to do some initial education about new diagnoses. We've had folks meet with behavioral health providers who had lots of anxiety and concerns that were preventing them from really utilizing outpatient services. And so we use that time primarily to address all of the psychosocial barriers that are in place for people. One of the things that we have identified with this cohort in doing this group visit is that our ideal patient is really someone who has low to moderate medical acuity, because the physician is really only able to spend about 10 minutes with the patient doing a medical exam. But folks who have moderate to high psychosocial need are really an ideal candidate for this group, because we're able to spend collectively as an integrated direct care team about an hour and a half meeting with the patient and trying to address some of those psychosocial barriers. I'm done.
Very interesting. I'm going to open up to questions, but it's Carol, I've got a question. Are you finding that people are coming in for these visits? Are people, what's your success rate of the numbers of ERs that are going? What percentage come in for these follow-up visits at 1 week?
We're actually in a data collection process. We didn't launch these visits until the summer, and we had a 4-week pilot, and over that 4-week pilot, we had about 40 patients come in over the course of those 4 weeks, 30 to 40 patients. So the pilot was really well attended. And now we've launched the visit as kind of an ongoing regular visit. And it's kind of hit or miss, actually. We have some weeks where we have 5 or 6 patients there. Today we actually have 7 patients scheduled to come to our group visit this afternoon. And then we've had weeks where we have had no patients. And the idea is that it is an accessible appointment that is always available. It's a standing appointment, so patients don't have to wait 2 to 3 weeks to get in for a follow-up appointment. And some patients are able to access that and others aren't. But I think it's a little too early to tell like what the regular attendance rate will be, because we're still collecting that data and looking at it and getting the clinic itself oriented to the visit so that everyone's really invested in it.
It's never good job. It's never too early to start measuring. So if they're supposed to be coming 1 week after, you might want to look at, are you looking at all ER trips, or are you looking at ER trips that were avoidable, and look at what your numerator and denominator is?
Yeah. Right now we're looking at all ER visits.
Okay.
Hi, this is Megan from Hudson River Healthcare in New York, and I was wondering how are you made aware that a patient of yours has been discharged from the ED or made an ED visit, and on the other side, how are you communicating to those patients that this appointment is available?
Okay. I'm going to let one of our nurse case managers jump in because I think she had something else she wanted to add as well. Do you want to go, Nancy? Oh, okay. So never mind. I'll answer the question. So all of our nurse case managers, one of our nurse case managers actually runs a report every morning, and we are able to pull through sophisticated algorithms all of our patients who were in the emergency room, and she distributes that list to myself and to our program director, and then all of our nurse managers own list of patients who have been in the emergency room.
So do you only work with one hospital? Is there only one hospital in your area?
We're working with our hospital affiliate. Most all of our patients at the clinic who go to the emergency room go to our hospital affiliate emergency room. We really only have one other hospital in the area that sees our patients, but most all of our patients go to our affiliate hospital. So
Okay.
It's fairly easy in that regard because we share a medical record and we're able to access those numbers fairly easily. And then I think the second question was, how are we offering the visit? We actually have several streams that patients are referred to our clinic for follow-up appointments. One is through the emergency room discharge list that I just described, where RN case managers are proactively calling our patients and reaching out to them and asking if they have any questions or any concerns, if there's anything our clinic can do to support them in their discharge planning, and they offer the visit at that time during those calls. Our physicians who are in the emergency room seeing patients will send messages to our scheduler and or to their medical assistant asking them to call and schedule follow-ups for the patient, and when they do, they're offering the visit at that time. And then I receive, the group visit coordinator, I receive a list of folks who were in the emergency room, and I also call anyone who hasn't been identified through those two streams and offer the visit to them as well.
So this is the care coordinator calling up post-release from the ER, and they're making contact with the member and reminding them about the availability of this. They may be getting some really good information. Is that documented in your EMR? So then at the time of the group visit, is that somehow accessed so everybody knows the same source of truth about that patient?
Yes, those telephone encounters where we're making contact with the patient is documented in the EMR, and they are accessible. And one of our nurse case managers, she's sitting here, her name is Esther. She makes a lot of calls and refers a lot of patients, and she also always forwards me a copy of that encounter so I can pass it along to whatever physician is going to be in the visit as well.
So this is Nancy, one of the RN case managers. Just to clarify, this isn't meant to take the place of a follow-up visit with the provider. It's and we're finding that, correct me if I'm wrong on this, Annie, but we're finding that it's particularly beneficial for new patients because there are a lot of questions that they have regarding their ER visits.
New patients to your clinic, or new patients in what way?
Yeah, new patients to our clinic. If a patient is seen at the hospital on the service of one of our physicians, then they don't have a PCP, then they are discharged with a referral to follow up here as a new patient. And it's particularly helpful, like Nancy was saying, for new patients to our clinic because they have an introduction to the entire integrated direct care team, and they're able to establish those relationships at that time, as opposed to coming in and having an appointment with their PCP and getting referrals to follow up with all of our different services. They're able to establish those relationships at that moment in time.
So do you bill for this visit?
We do. We bill either 213 or 214, depending on whether or not the attending's present.
How did you decide who should be on the integrated team, the healthcare team?
So I was hired into this position as the group clinical therapist last October, and I was told by our program director that this was our top priority. But if you look at the literature, nothing like this has ever been done. Group visits are very popular, and all of the literature indicates that they are significantly more effective in increasing or improving patient outcomes than traditional appointments. So we knew that group visits were efficacious. We just didn't know about this particular application. And when I was first handed this task for developing a transition of care group visit, I was a little overwhelmed because patients go to the hospital for lots of different kinds of things. And so how do you create a visit where everyone's needs get met? So for the first 6 months that I was in this position, I actually spent my time meeting with every single patient, at least those that I could. I wasn't always able to, but as many patients as I was able who came in for follow-up appointments. I had a survey and some questions I asked them about their experiences in the hospital, what were some of the barriers to them accessing outpatient services as opposed to going into the hospital. And I tried to get a good sense of what folks' needs were. And then I used that list of needs to identify the providers who would need to be present in the visit in order to help those needs be addressed.
And what metrics are you, I know you mentioned that you're kind of doing some data collection right now. What specific metrics are you monitoring?
So right now we're casting a really wide net. Like I said, this is kind of a formative evaluation that we're doing of the project right now to get a sense of exactly what we can measure and how we're going to measure it. So we're really collecting a wide net. When patients are referred or when patients are scheduled for the group, I go through and I make a note of primary health indicators, their A1C, their blood pressure, their lipid panel. I make notes of all of these. I'm tracking those over time to hopefully compare them to the control sample that is patients who do not come to the group visit. But it's just too early to actually be looking at those statistics specifically. Of course, we have patient satisfaction, and those are overwhelmingly positive. Folks who have responded on satisfaction say that they would rather go to a visit like this than a traditional visit because they're able to access all of our services that we provide. So patient satisfaction is high. I think over time the goal really is to look at ED utilization. That's the purpose of the visit. That's why the visit was established. But it's too early to make any comparisons right now. But that's the goal, and I'm tracking all of that.
So this is Nancy again. In addition to the group visits, though, the RN case managers try to make contact with all of our patients who are discharged from the hospital and our patients who are seen in the emergency department. So whether they go to group or not, we still try to interact with them and find out if their needs are being met, if they were able to get their medications, their DMEs and that kind of thing. And so in those particular cases, we're performing the some of the same. We're evaluating some of the same needs and making referrals and helping them access those things, but it's just not in a group setting.
Yeah.
Okay, great job, Providence. I'm going to move us along in the interest of time. Thank you for starting us off. Who wants to go next?
Sure, I can talk. This is Laura.
Thanks, Laura.
Yeah, sure. So we have a little different situation here than what was explained there, because we have 10 clinic sites in 3 different counties. So I work with about 14 different hospitals. So having a delightful meeting to sit down and have that discussion is a little bit more challenging on that. But we do have a pretty integrated process for how we work with both our diabetes patients and also with our emergency room and inpatient utilization pieces. So let me start out with the inpatient and ER utilization piece with that. We have case managers that round at some of our primary hospitals that are really close to our area on a daily basis. We have 3 hospitals we do OB deliveries at. We do about 1,700 deliveries a year between those 3 hospitals. And so she starts out her morning at the OB department and meets with moms that delivered in the last 24 to 48 hours. She schedules moms for post-op appointments. For mom, if they had a C-section, come in for a wound check, get the staples taken out a week later. And then if the baby's going to be following up with us, we also schedule the baby for their newborn appointment within 24 to 48 hours of discharge from the hospital. If they need WIC, Women's, Infant, and Children support, we'll schedule that appointment right at the same time, right there at the bedside with it. And then she tracks to make sure that those patients are seen here. So I just did some statistics earlier this week for that hospital that we do. Last year, fiscal year, we had 809 newborns that were to follow up with us within 24 to 48 hours. We had 808 show up. Only 1 did not show up within that 48-hour period.
Woohoo!
Yeah.
Awesome.
Yeah, 99.9%, I said. So it's great. The moms love this because they've got somebody right there at the bedside with their laptop. She can schedule them in with their appointments. She gives them appointment cards for all that. She gives them a nice immunization record. We give them a nice welcome to VNA, how to call the doctor after hours if your baby's sick or you're having a problem. So all that information's gone over there, right there at the bedside with them. And we've expanded that to one of our other hospitals, and we're working with a 3rd hospital where we do OB deliveries to do that piece. But when this case manager is done, then she goes around through the other departments of the hospital, the emergency room, and all the inpatient units. She meets with the unit secretaries there and or the case managers in the hospital. And they have, like in the emergency room, so if somebody comes in at 2 o'clock in the morning, they have a manila folder that says VNA on there, and so we don't have access to their EMR, unfortunately, so what they'll do is make a copy of that face sheet and any pertinent labs, test reports that might have been done, and if they do have the discharge summary, we'll get that piece there with it. We set up appointment times at all of our clinic sites with an MD for ER hospital follow-ups that the case managers will schedule patients in, and they're set Monday through Saturday from 10 a.m. to 2 p.m., and we did appointment cards for each of the hospitals, so they've got them over there, and so they can talk to the patient, and they say, you know, Mr. Hernandez, you need to follow up with the emergency room, or from the emergency room with your doctor, and VNA can see you Monday through Saturday at either 10 a.m. or 2 p.m. What day and what time will work for you? And then he'll say, oh, Thursday at 2 o'clock will be good. They'll circle that on the appointment card, and they'll give this to the patient. It is amazing with all the patient papers that they leave from discharge from either the hospital or the emergency room. They will lose all those big pieces of paper, but that little appointment card they seem to show up at the front registration desk with and hand it to us. So they notify us then when we make rounds on there that they've got that patient scheduled, and we scan in those reports so that the provider has that information when they do show up over here. The flip side of that is maybe they don't show up. So that's the second part of what the case manager does is they do track those patients to make sure that they're showing up, and then we get in touch with them. If there's a pretty significant concern that we have that the patient definitely needs to be followed up with us, say they need an INR done at post-discharge, we need to verify that they do have their medications right, or there's some concern about ongoing needs for them, we will send that case manager over to the house, kind of like a community health worker making a visit on in there, and we may even send an RN over to the house if we need to with it. But we do try to go out and contact those patients with that. So we do this at about 3 of our hospitals right now. We've got a 4th one about ready to come on. I work with about 11 different hospitals otherwise that they just send us the information when because their volume of our patients is not nearly as high, but they know how to contact and interact with us to get that information for follow-up for those patients. So that's kind of how our ER inpatient piece works. I don't know if anybody has any questions on that.
Hey, Laura, that's an amazing program. How did you start working with the hospitals? I mean, that's wonderful partnership and innovation partnering with the hospital. How did you get them to let you in and make rounds on the floors and have access to their stuff? How did that come about?
Yeah, that's been an interesting piece on its own because in working with 14 different hospitals, you can very quickly tell in the conversation about care coordination that they either get it or they don't. And those that get it, they really want to be involved and get moving with this and have that piece working with it. So the piece that you work on from that is, we try to work with care coordination. What is one of the biggest areas that the hospitals are trying not to get dinged on from their Medicare numbers is that 30-day readmission rate. So that's where you start with the conversation with them. We can help these, and we take patients that have Medicaid or are no insurance. And so these are their hardest patients to find places for them to go to post leaving the hospital, whether it be the ER or inpatient. So we can be an option for them to work with them on it. So I think when they start listening to you or you start the conversation on off, it's like there is places they can go versus the emergency room is like the worst place for a patient with no insurance because they get the ER on-call Russian roulette, I call it. It's whoever the doc is on call. And it was very apparent about a year and a half ago that the hospitals are tracking by doctor and not by patient. So in one of my cases, I have a patient up in, and that's the other secondary piece of this that I can talk a little bit more about, is what we engage and work with our managed Medicaid plans. So they're sending me reports of my ER flyers too. So that's another whole arm of this that we're working in. But like up in Elgin, I know I've got a patient up there that has been in and out of the emergency room 23 times at the 2 different hospitals. But each time he comes into the emergency room, he gets assigned to a doctor. So when the hospital's running by doctor what's going on, they're not catching that this guy's been in 23 times, or well, half the time, 11 times one hospital, 10 times the other hospital with it. They're only tracking it by doctor, so they don't track it by patient. So it was like when you talk to that group up there, like, and we've been over to his house. Well, he's not there. So whatever address he gave to the state when he signed up for Medicaid, he's not really there. My guess is this is probably a homeless patient, and we know he's got asthma as an issue, and when we get the heat and we get the cold weather, he's in the emergency room. because he's not probably on medications that will cover it. He's got a managed Medicaid plan. This would be a real easy hit to be able to get him some support services to get that piece going with it. So what my work is now we're just about ready in the next month to sit down with these frequent ER flyers that I'm getting from my managed Medicaid plans that have been in the emergency rooms or the hospitals 5 or more times in the past year, and sit down and let's talk about these patients, because some of them have never made it to our clinic. So is it easier for the patient to call 911 and have an ambulance take them on over to the clinic because they can't have because they don't have transportation to come see the clinic on a regular basis? And maybe I need to send my house calls, my nurse providers, to go out to the home and do home visits then and do that evaluation there at the home, where they can do blood tests, they can do x-rays, they can do ultrasounds, we can do EKGs, we can do medication reconciliation and redosing the medications with it. Or do I need to set up transportation for them to come on over to the clinic, with it? So there's a lot of different arms that you can start moving out with this. So any day it could, happen. But that's kind of what happens with ER and inpatient there. I don't know if anybody wants to know any more about that or what.
A great job explaining it, Laura. I'm going to open it up for questions, comments.
This is Tracy from. I was wondering, have you checked it into service agencies have a database where they're tracking those who are homeless that are getting different social service agencies? Because that's how I the ones who were lost. And our system was through the social service database.
We do not have that available for us here in Northern Illinois. I know there is one called WOW, I believe it is. It's more in the Chicago area. And if anyone's from that area or can talk to that more, they can. But I know there is one that's been started by the University of Chicago for the social agencies. We did apply for some grants in collaboration with a hospital up in Elgin, Illinois, that was working specifically for that in the Elgin region with all the FQHCs and all the hospitals up there and the social agencies, and that grant was not approved with it. It went obviously to another location there with it. But I would love to have that next level of integration from hospital to clinic to our social agencies to be able to share that information on out there. But we don't have that yet in this area that I know of.
I'm in central Illinois, but ours isn't even health ran. Ours is just the service agencies ran for those who are getting HUD funding. And so any place that's getting HUD funding has to have a system information goes into. So I don't know if you might want to look and see if that's available, because we've been able to go through all of our HIPAA pieces to be able to get into that information.
I'll definitely look into it. Thank you.
Other comments or questions before we move on? Okay, well, thank you very much, Laura, for presenting. You've got a lot going on there, and thank you for sharing. Let's move into session 3 content. How do we figure out who needs to be in the network? Sherry, you want to take it?
Sure. So I think, some of you have done the 2 examples. You gave a really nice overview of kind of where your cohorts were and what services you needed to offer. And I think as you think through your clinical models and how you're actually going to manage that particular cohort, what services you're able to offer, what you're capable of developing and implementing, some of them you may not have today, but like the group visit was something that I think the Alaska group you came up with. It wasn't something you had available at the time, but you actually developed that. And then it's important to understand, where are your gaps? If there are certain services, programs that need to be offered and you don't have them and you can't develop them, then you really need to go out and identify, okay, how are we going to identify that partner that is going to help us fill that gap? And there's a laundry list of criteria that you can use. These are some ideas as you go about trying to determine who should be in your clinically integrated network. Some food for thought around this. These are not listed in any order of priority. It's just a list. And, you know, it depends upon the situation. Sometimes it even depends upon the service and kind of what's available to you in your area. So, for example, if you decide that you do need a subspecialty and there's only one, well, you know, some of this criteria doesn't matter. But it's something that you should be thinking about. You might want to prioritize based on the type of service or specialty that you believe that you need. You know, the quality, efficiency, and financial information sometimes isn't readily available. And a lot of that depends upon the data that you might get. And Derek is going to go through some examples about how he's used that data to identify potential, you know, network partners. You know, is the partner that you're looking at, do they have aligned vision and goals? And I think, Laura, you alluded that to a little bit around your conversations even with the hospitals. You know, and it's getting to the point where, are you talking the same language? Are they thinking about this the same way you are? Are you aligned? You know, we talked geographic considerations, and particularly in some of these areas where folks don't have transportation, can be huge. That might be a very, very, very big priority for you. Capacity. You know, I know many areas throughout the country have capacity with mental health providers or behavioral health providers. And are there things that you can do to maybe agreements in place to help with access issues around that? And then also, you know, the things that you should always be looking at when you're moving into value-based contracting are, what are those contract terms? And how do those contract terms, how are they going to apply or not apply to anyone that you're bringing into your network? So what that means is, if you've got a clinical model and the clinical model says you need to deliver this particular service to affect the outcome, and you go out and you partner with somebody who's delivering that service, then you might want to be thinking about, okay, you know, if I'm going to be held at risk, then maybe I need to think about how my contract terms are also going to affect determining the partner. Questions, comments? Make sense?
Yes, this is Laura again, and you're right. I think everything that you said, I fully can follow with where you're at. That contracting piece is one of the parts that we're starting to work in here with it. As you're trying to pull this together, that it's all got to work together for everybody.
Yeah, exactly. So, you know, once you identify the partner, then you need to think about, what's the structure of our agreement. And again, these are some examples to be thinking about. You know, I think sometimes I think the two examples, and maybe Laura and Annie, you can chime in here about, it sounded like it was more of a collaboration effort, not necessarily anything too formal between the partners that you were working with on your efforts. It could be a memorandum of understanding, could be a handshake, could just be that, you know, you have a firm agreement about how this is going to work. There are some things out there called a compact, which typically is more around care coordination, and it actually helps set up a little bit more structure between what's going to happen between primary care practices and specialists. This is typically where we see this kind of agreement, and it allows for, you know, the opportunity to promote timely scheduling and availability, make sure that there's availability. So if you have some things where you need people to get in within a certain period of time, you can structure this agreement that says they will keep slots open in their schedule to allow you to get in. And sometimes that ability to give them volume actually helps with that agreement. You know, it's the communication between the parties is also established. You're going to send them information ahead of time that they require, and in return, they'll send you information about the outcome of that visit and what might need to happen in the care plan. So there's better communication. That's another way. Then there's formal agreements, and it could be that you actually subcontract or subdelegate particular portions of your clinical model to other people, and certainly you might see that if you are going to, we'll go through some more examples here, but if you're going to refer to a specific person or specialty, that you actually are going to subdelegate some particular items and you want to subcontract with them. And then there's the partnership, which is a new company is actually, you all become partners, you form an IPA, you form an ACO. It's really more of a formal agreement. And one of the things to keep in mind as you're doing this in regards to value-based contracting, and this slide we showed at the very first sessions about what it is, and again as you move from left to right, your level of risk increases. If that's the case, then so should too your sophistication of integration and your degree of structured agreements. Because the more risk you're taking on, you want to make sure that you have a better handle of control over opportunity for success. So the greater the risk, you want to make sure that you actually are going to have more integration and a more structured agreement. And here's some examples as we talk through the different types and the clinical integration that would occur. So for example, you're a primary care ACO, you collaborate with a local hospital. We just talked about a couple of examples of that today. And the hospital is willing to provide an ADT feed of inpatient admissions for your attributed population. That is a sample of, it's more of a soft agreement. Again, there's nothing in writing, but it gives you an idea of how you're going to collaborate. The compact, again, where a primary care ACO has compact with certain specialty group, and it allows for pre- and post-consultation exchange. We talked a little bit about that. You know, the management of protocols for common conditions, who does what. I worked on a project here in the Twin Cities between primary care that was made up with a pretty hefty group of internal medicine docs, and they were really working around with heart physicians, with the cardiologists, around management of congestive heart failure patients. And it was trying to figure out, okay, at what point should the primary care physicians transfer that patient to the cardiologist? It was a huge discussion, and this really helps establish kind of where that point is and what the communication is back and forth, and also to establish common goals. You know, and a common goal might be, we're going to keep those CHF patients from getting into the hospital, right? We're going to manage them so they don't need to get to the ER, and that really helps. Then a subcontract or delegation. Let's say you're a primary care ACO, and you have formal agreements in place with the behavioral health group that you've decided that you're going to refer all attributed patients with behavioral health needs to that behavioral health group. And so you're essentially going to delegate or subcontract with that group to provide those services. And then again, the partnership, the ACO or IPA, you again got formal agreements between the partners to form a new company. And in this scenario, a lot of it is around the accountability and the ability to really address those who may not be performing in that partnership. It should accommodate both. You're going to formally align incentives. If it's a shared savings agreement, for example, how are you going to share those savings with the folks delivering the care? And then how are you going to address the folks that are not performing? And that formal agreement should actually include those components. Just a quick overview of that. What questions? Anything? Any comments? Any thoughts? The folks that presented, or even those that didn't, if you have some folks that you're thinking, or you have some integration, you have examples of how you're partnering with them. What kinds of things do you have in place?
Hi, this is Renee from Cascadia. My apologies for joining us a minute late, but I actually came from a meeting that was quite related to this. We've been just getting into using pre-managed care, and I'm kind of fuzzy on the background information, but it's basically a system that connects all the hospital providers with primary care providers or physical health providers. And we as a behavioral health care company are very fortunate that we now have access to this. So every time one of our clients is discharged from one of the participating hospitals, they have to be a Medicaid client, we get all the discharge information, so reason for admitting, diagnosis for what they're treating. And not only does this help us treat individuals, at the individual level, but I think it's really allowing us to look at trends, whether it's by level of care, diagnosis, clinician, site, program, all that good stuff. So the way I'm just so appreciative of the technology that we have access to, and the way that we're able to use that with our primary care and hospital partners to really address what we're seeing as a lot of the behavioral reasons why people are going to the ED. For example, in the meeting I was just in, we found out that between March 1st and July 31st, 1,376 clients were admitted to this particular hospital system, and of those 1,376, only 620 are unique individuals. So even that one point right there gives us a lot of really great information to start seeing who we need to hotspot to decrease the ED utilization.
Yep, that's fantastic. And certainly, we're going to talk more. I think our next session, Carol, is going to be actually on the technologies to support clinical integration, because you're right. I mean, technology certainly helps. You have to make sure that it's meeting the business requirements. You can't just build it and expect people to come. It really has to fit the need that's available, and then they'll adopt it for sure. So that's great.
Right.
Good to hear.
And I think that we're fortunate in that when we're looking at the reasons for why people are going, when you have 70% of them are behavior related, I mean, to me, that obviously speaks to the need for the partnership between behavioral health and primary care to address why people are going to the emergency department for psychiatric or behavioral health reasons.
Absolutely.
I think you'll find when you make follow-up with those people, I'm just speaking from experience, sometimes the ER disposition they'll give you doesn't always match what the patient tells you why they went.
Absolutely. And what we're finding is that there's certainly a lot of discrepancies within how, on the hospital side, data is put into the system. So sometimes there is an ICD code for, the diagnosis or for whatever, but or sometimes it's missing. So we're in the very early stages of this as a behavioral health provider, and I think joining the consortium a little bit later on, but it's such a great opportunity to figure out how we can do this population data and continue to partner with our primary care providers, because I'm sure, like many other folks on the call, I feel like that for the population that I serve, where we need to move the dial is on the behavioral health side of things and not the primary care side of things if we want to do healthcare transformation.
Well, and the important thing is you've got the data, you're looking at the data, and I think when Derek presents, he's going to bring that to life as well.
Well, I would argue even more than that, we have the willingness from our partnering organizations to work with us to provide us with that data and to work with us to provide the services so we're meeting common goals. There have been times where not everyone is as willing, and we're quite fortunate that we have a group of willing partners to support us, support themselves, and support the clients that we mutually serve.
It's important to look at what everybody's agenda is. I think Laura hit it on the head. Working with some of those partners, they may not have been interested, and now with the 30-day readmit penalties, all of a sudden they're interested. So it's not only your goals and what you're trying to offer, trying to understand what the others, what you can do to help them. So it's right. Identifying, like session patient needs today. What are your patients' needs, and who are the providers best to work with you? Sounds very exciting.
Yeah. Hi, Annie. I want to throw on one more point because you just mentioned that, Carol. I think what this is really doing is allowing us to provide leverage for sustainability. So, at Cascadia in Oregon, we're going after the CCBHC, demonstration grant, so Certified Community Behavioral Health Care Clinics, and we know that at the end of the 2-year demonstration period, if Oregon selected that, the state's not going to have additional money to fund the services that are provided in this model. So one of the things that I'm working on right now is, I know what our data is, but also kind of looking at what the CCO metrics are and what the state metrics are for CMS, and kind of doing a crosswalk between, those two things as well as CCBHC, because if I want them to continue, if I want the CCOs to pay for the services that we're providing at the end of the demonstration period, I need to start now to plan to show them how we're saving, the system money and how we're actually helping them achieve their metrics that they're held accountable for.
Yep. That's right.
I just am in Alaska.
Go ahead.
I was wondering, so I've been looking at pre-managed care, and I would like to reach out to whoever was speaking. If you could offline give me your information, I'd love to talk to you.
Yeah, this is Renee, and if my information's not there directly, I'm sure that AJ or Carl or someone can give you my contact information. I'd be happy to set up a time to talk about my experience with that.
That'd be great. Thank you so much.
Sure.
All right. So let's introduce our guest speaker. We have Derek Peterson. He's works at Optum. He's a VP of Medical Informatics and Consulting. As Carol mentioned, he does a lot of work around data, mostly claims data, and he's been with us for 5 years. He leads consultants, and they do a lot of work across the health system as regards to providers, payers, and also employers on data analysis. And he's going to talk a little bit about how you might be able to use claims data to identify providers who might be more efficient related to at least cost. So I'll let you take it away, Derek.
All right. Well, thanks very much, guys, for having me today. So identifying the groups of providers that you want to work with, as Sherry mentioned, it would be great if we had a nice, clean data that we could use to identify folks and measure their efficiency and that sort of thing. And it would also be great if we had some information that indicates how easy or difficult they are to work with. Are they sending you follow-up notes, and are they helping you with your care coordination efforts, and those sorts of things. Unfortunately, we're most often working with the absence of data, especially on some of the kind of clinical care delivery and maybe hospitality type metrics. To the extent that we can leverage claims data, that can give us a pretty rich view of who are maybe some providers that are worth considering, as partners or collaborators, in your area. As well as maybe some that you may want to cross off your list as, not being the folks that you want to work with just in the best interest of the population. And again, as Sherry mentioned, it has a lot to do with, a shared vision and, even a shared passion for the population. So this first step is just, talking about looking at financial results and, selecting the right, providers and caregivers to be in the network and how those decisions can impact the performance of the organization as a whole and the competitiveness of the organization. So I think we can just jump ahead to the next slide, Sherry, if that's okay. So as I mentioned, to the extent you have claims data available, that can give you a big leg up in terms of, looking at performance of providers within a population. And we'll just look at an example where this is an example where we have a group of providers that have come together to take risk on a defined Medicaid population. And we get data for those members from the state, and we can use that data then to start looking at different performance metrics for providers within that patient population. So we leverage the claims data, we leverage the eligibility information related to the members, we look at some provider information. In our case, we're running the claims data through the Symmetry episode treatment groups, and we can use that to provide some context for the care that's being delivered, and we can use those episodes of care then as a unit of analysis. And we also look at episode risk groups, which are really an aggregation of a member or patient's risk based on the diseases or conditions that we see in the claims data. So folks with multiple chronic conditions, for example, are going to have higher risk scores than let's say younger members that we don't see any evidence of chronic disease or condition in their claims data. So then we can use those data elements to create some metrics and apply those metrics to different providers. And the metrics could be assigned to providers based on an attribution of a member to a provider or the attribution of an episode of care to a provider. So you may have a primary care provider that's responsible for a member or a patient, but that primary care provider doesn't necessarily render all of the care for that patient. So the patient may be seeing a dermatologist for a particular condition that the primary care doc doesn't participate in, or an endocrinologist or some internal medicine subspecialty, for example. But overall, we still consider that primary care provider to be responsible for that patient's care. And as such, the primary care provider really needs to think about, well, where should I send my patients so that, they're getting efficient care, I'm getting good, follow-up on those patients, and that, I get good coordination with those other providers. So those are some of the things that we can look at. And then finally, we can look at some metrics, high-level metrics related to utilization as well. So let's just jump into some of the examples and we can kind of talk through those. This view is really just kind of a process view of how we can take data in from various inputs, the claims data, for example, enrollment provider data. We run it through this process, and then we produce some reporting and analytics that can be used for decision making in a variety of areas. Who do you want to participate with from a collaboration or network perspective, to who are members or patients that may be in need of outreach, to various utilization metrics like we talked a lot about earlier about ER utilization or inpatient utilization, that sort of thing. So this is just kind of a flow of how the data goes through from initial acquisition of the data to processing to producing some reports. So I think the next slide starts to get us into some of that context. So in this example, we're just trying to make some comparisons among clinics. So in this case, we have a group of FQHCs, of primary care clinics, that are responsible for defined patient populations. And using this, we can start taking a look at, well, how are these clinics doing relative to one another, just to give a sense of, what are the illness burdens of the patients being cared for by these clinics? And then you can use that to start looking at things like staffing decisions, and do I have the right mix of providers at that location to take care of the diseases or conditions that are most highly represented at those clinics. that's just kind of a high-level view. Let's go ahead and move to the next slide. And this is just kind of an overview of explaining the different needs of a Medicaid population, for example, compared to a commercial population. So we know in this population, for example, that psychiatric services, obstetric services are big drivers. And I know this is a bit of an eye chart and hard to see on the screen, but really it shows how in a Pareto diagram like this, the diseases or conditions in a Medicaid population are just very different than the diseases or conditions of the commercial population or a Medicare population for that matter. And it's just important to consider that when looking at, well, which provider specialties do I need to, really establish good relationships with to, help take care of this population. Let's go ahead and go to the next one. This is just further drill down on understanding the different diseases or conditions that may be driving cost within the population. So again, we talked about behavioral health or psychiatric diseases and conditions, and then within that, what's really driving cost and utilization. And in a commercial population, it's depression and anxiety disorders. In a Medicaid population, a lot of times it ends up being schizophrenia and bipolar disorders that are really big drivers. And so making sure you have access to psychiatric services and behavioral health services and counselors is going to be important. And as well as we talked a moment ago about making sure that when you're looking, if you have multiple clinics, where are the vast majority of those members located, and do you have coverage for those clinics that have the greatest need for those types of services? So again, we're trying to let the data be our guide in that respect and help direct us to the clinics where there's the greatest need. So let's go ahead and go to the next slide. This is just an example of some inpatient metrics. So we can take a look at this from a clinic perspective. Again, a member or a patient is attributed to a primary care clinic. You can also take a look at this from a hospital perspective. And so you can start creating some metrics around those inpatient stays that are going to be important to making some assessments on how these organizations are performing, whether at a clinic level or at a facility level. You can start measuring things like the total count of admits. You can use the AHRQ definitions for ambulatory care sensitive conditions to look at potentially avoidable admits. And then you can look at 30-day all-cause readmissions as well. So when you start to take some of those things into account, you can look at, well, what are the real drivers? Which clinics seem to be doing better than others on a disease or condition adjusted basis? And you can also start to drill in to see, all right, well, what types of services are going to these various types of hospitals, and what are the various rates associated with those, especially as it relates to discharge management and readmissions, medication therapy management, and that sort of thing. That's really critical in impacting the readmission metrics. So the next view here is around ER utilization. Same type of thing as with the inpatient. We're really taking a look at the ER utilization, and in this instance, we're looking at treat and release ER visits. So we're not looking at those folks who presented at the ER who were subsequently admitted. We're really looking at those folks who presented at the ER, were treated, and eventually released. It didn't result in an overnight stay. It could have resulted in an observation stay, but not necessarily an overnight stay from a billing perspective. And again, looking at things like overall utilization rate, We can look at things, again, based on the claims data. You can apply some avoidable ER visit criteria. Now, our experience is we use the AHRQ ambulatory care sensitive definitions there as well. So if you shouldn't end up in overnight in the hospital for diabetes, you shouldn't end up in the emergency room for diabetes either. So that we're just applying that same rule there. But we also apply some, minor acute conditions as well. So people are ending up in the emergency room for headache or low back pain, urinary tract infection, ear infection, those types of things as well. We flag those. And again, you can create metrics then to say, all right, well, what are the rates of utilization there? And earlier folks were talking about, what we call frequent flyer ER utilizers, and what are the reasons they're going to the ER from a clinical perspective? What are the reasons they're using the ER from, just an care access perspective, and maybe, social determinants as well. So again, metrics that you can use in taking a look at these. The other metric that you could potentially add into these is, how many of these folks convert? We're looking in this case specifically at treat and release ER visits, but you could also create metrics that look at conversion to inpatient. So, if you wanted to assess a hospital, what rate do folks present at this facility that are subsequently admitted? And then if you would examine that at a kind of a disease or condition level, that can give you a sense of, is that a potential cost driver for the population? All right, so we've gone through quite a few of these. Before we get into, the opioid kind of view of the world, I just wanted to pause there and see if there are questions or comments on kind of measuring the facility piece, the ER utilization, the admit utilization, that sort of thing. And Sherry and Carol, if you have comments you wanted to make on that as well.
Is there questions first?
Maybe one comment I'd add is, in the absence of having the claims data as a source to start measuring this type of information. Earlier I think folks were mentioning survey data and that sort of information. And in the absence of having the claims information, starting to collect that type of data can be helpful as well. And again, with an eye toward figuring out, well, if I'm working with multiple hospitals, am I able to discern any difference among these hospitals in terms of some of those key metrics? ER utilization, readmission, avoidable admissions, discharge management, those types of things.
Yeah, and I think even if you look at it, if there's a conglomeration of you coming together to form an ACO or a clinically integrated network, and you see that, even earlier on some of the avoidable conditions, those with chronic conditions, and you see folks that might have, better utilization or, more efficiency in some areas than others. Sometimes I think, the FQs can start talking with each other and they can start finding out how are you managing that? And it just really promotes some of that sharing and the collaboration within the entity, and maybe the adoption of some additional practices around a clinical model where one place has been more effective than another. That's another way to use some of this information.
Yeah, that's absolutely right. So I'm sorry, any other questions or comments before we jump into this next piece?
What's your reaction when you see some of this data? Are you familiar with looking at reports? Is this something new to you?
think I've rolled them all into silence.
This is Laura. This is exactly what we look at on a regular basis with our MCOs, and I wish I had it so nicely organized from the hospitals, but with working with the different ones, we don't have quite that. They just don't have that capacity yet to be able to pull out our patients and put that together yet with it, but I do get it from the MCOs.
Laura, that was my thought. I've worked with like 8 different MCOs and different hospitals, and everybody gives me their report. But it's bringing it all together so I don't have, 8 different spreadsheets to look at.
Yeah, absolutely.
And that's what I was going to say, too.
Yeah, absolutely, and that's one of the challenges as you start collecting the data from multiple different sources is kind of bringing that together to tell the story. The other thing to consider, as you're bringing those data sources together is how consistent are they in their definitions and their measuring, especially as you start to make comparisons among organizations. So just a grain of salt with the review of reports that you might be getting from different organizations that potentially measure the same thing in concept, but in practice may have different underlying definitions that can impact those results.
Derek, I don't know if you heard it earlier. I think Laura mentioned it. She piqued my curiosity on that with the ER frequent flyers. Depending how you report it, are you reporting it by individual patient ID, whatever, versus who the PCP or the admitting provider is? When she identified that it was each time they went to the ER, they got a new doc, so they weren't showing up as frequent flyers. So just how are you defining things, and what are your data definitions?
Right. Yeah, absolutely. So if you're pulling this by provider, to that earlier point, it doesn't look bad because you get a different doc each time this person, shows up in the emergency room. But then if you pivot that and you look at it by patient, then all of a sudden, it springs to life and you're like, oh my goodness, this guy is going to the ER, 3-4 times a month, and we really need to get him, hooked up with a primary care physician in a clinic setting to try and avoid these visits. It's going to be better for him, and it's going to be better for the system. So just quickly, I know, we're approaching the top of the hour here, but one of the other things that we looked at, again, leveraging claims data and making comparisons among providers for, kind of assessment of performance, who do we want to work with. This is opioid utilization. This is an example that's more patient-centric, but we also do provider-centric views of this as well. And so, opioid prescriptions are, becoming top of mind for folks. It's a hot topic of late, and we take a look at opioid prescribing by provider. We take into account the diseases or conditions that the opioids being prescribed for, and then we can start to make some comparisons about rates and the frequency at which a provider may be writing opioid prescriptions, again, within the context of a disease or condition relative to his or her peers. So, do you have patients that have a greater likelihood of getting an opioid prescription if they go to Dr. Jones versus Dr. Smith, that sort of thing. So trying to call that out and, take that into account as part of an overall ACO assessment or an overall, collaborative assessment is kind of a key indicator. So that's just an example of potential overuse, potential overprescribing of opioids. The next slide, I think, yeah, this is polypharmacy, and this really isn't necessarily a comparator for assessing which groups or providers you might want to work with, but this is just another view that we look at when doing patient outreach and that sort of thing. How many different drugs is a member taking? How many different prescribers are prescribing for this member? How many different pharmacies are being used? Because again, ideally we have some coordination at the dispensing level, at the pharmacy level, to avoid potential drug-drug interaction. But when you're looking across multiple providers, multiple pharmacies, there's a good chance that can get dropped. And this is just an example of one of the ways that we start to identify those folks that have multiple prescriptions or polypharmacy.
I just had a question.
I'm sorry, go ahead.
I just had a quick question on that, or just a quick statement on the polypharmacy piece of it, because it seems like, and this is the nurse part of me that's coming back, and this is Laura again, sorry, I'm probably talking too much today, but it just seems like you have patients that we have to watch those number of medications. I truly understand that, and that they're filling them and taking it as they're ordered. It's the entire medication management, so it's not even just the number of medications with it. And then dovetailing that and looking at that ER inpatient hospitalization rate for individuals with really high numbers with it, because that may be keeping them out of the hospital if they're taking it the way they're supposed to be taking it, and also being monitored with it in the way that they need to be too. So just kind of medication prescriptions can be very costly and expensive, but if the alternative could be if they're not taking what they need to be, they may need to be in the hospital too. So it's kind of a fine line, absolutely, or a balancing piece with it.
Absolutely agree, yeah. And this example is really just calling out some of those kind of high outlier extreme cases where you've got 30 different providers writing scripts for a patient that goes across 10 different body systems where they're getting drugs for cardiac and for endocrine and for orthopedics and for derm and for neurology. This person is full by breakfast because they've taken so many pills. So it's just kind of looking at those kind of fringe cases, but absolutely agree. The medication compliance and therapy compliance, keep them out of the hospital or out of the ER. In contrast, take the pills. It's better for you in the long run, but we just want to make sure that it's coordinated and we're doing the best thing clinically for the patient as well. This last piece, I just threw in some different resources that can provide at least some benchmark information that you can take a look at for things like ER utilization, admissions, readmissions, and that sort of thing. So in the absence of claims data, if you wanted to get some high-level metrics around ER utilization, for example, on a Medicaid population for a particular geographic area, the Kaiser Family Foundation has some good information out there that you can use that looks at utilization, looks at coverage information. AHRQ, the HCUP, has an interactive query tool that you can use to take a look at things like ER utilization, admissions and readmissions, and takes a look at it by disease and condition, and gives you some kind of metrics that you can use to potentially make comparisons. So I just threw those out there as some sources to explore. Again, just to give some context around those for a particular market. So
Thanks,
Sherry,
Derek.
I think that's it for the data piece of it.
Appreciate it very much. Thank you so much. I don't know if there's any last minute questions or if we want to go on to homework. Carol, do you have a...
No, I think don't forget to download the files. We really appreciate Derek's presentation, and he went out of his way to give us resources so you guys could have some benchmark data. Sherry, do you want to do the homework, or should I?
Go for it.
Okay, so you're not getting away without homework for session 3. We want you to work based upon what you came up with for the homework today. What were the cohorts that you identified? And think about, given their needs, what would be 2 potential partners, 2 potential community partners you'd want to work with. And be prepared to, I'm going to look for, volunteers again. Again, thanks to our presenters for today. How would you go about identifying who those partners are? How would you find them? How would you select them? What criteria would you have? What process would you use? Just all the things that we've talked about today. You can go back and look at the presentation where Sherry pointed some things as capacity, capability, geographics. Start using the information we share with you. Who would you select and why? Why did you choose them? And given the different types of partnerships that Sherry reviewed today, what do you think would be the model for the partnership? And again, feel free to go back to the PowerPoint, reference the material that's in there. If you have any questions, reach out to me. Don't forget, there are some really good resources we found for you. We think they're pretty good, some interesting articles. There's a lot of material to cover, but we want you to have some things to read about after our sessions. Don't forget to do SurveyMonkey. The link is on your screen there. We will see everybody back here, let's see, for session 4, November 1st. I think you're really going to like that one. Natalie is coming back, and she's going to talk about, okay, you found your cohort, you found your partners. How do you go about and start putting things together? Okay, any questions or comments before we let you go a whole minute early? Okay, please use that minute to do SurveyMonkey. Thanks, everybody. Great participation, and we'll see you back here November 1st.